Let's talk about frontline treatments. SSRIs. We're all going to do it, even though I told you they don't work well, right? If your patient is really anxious, panic, general, social, that's a pretty good sign to use your SSRIs. We don't think it's going to help their empty depression. It's not going to help their cutting behavior. It's not going to help their dissociation. So just let's be real. They're safe. And that's why we start with them, right? But they're really not effective for a wide range of borderline personality symptoms. But it's okay to start there. You hear me, right? You can start there because it's easier, but let's just be realistic of what your outcomes might be. 2010 older meta-analysis would say the antipsychotics will give you moderate effects for cognitive perceptual disturbances, quasi-psychosis, paranoia, and really help anger. You heard Dr. Citrome, Les is up here talking about agitation management and other folks. If you block D2, you lower anger in schizophrenics. If you block D2, you lower anger in the forensic population. So there is something about the atypical antipsychotics there. The antidepressants, not so great, maybe anxiety better than the other things. And your mood stabilizers, divalproex kind of things, the things we use for bipolar disorder, can lower impulsivity, anger, anxiety. Some have antidepressant effects, some don't. They have the largest, widest ranging global effect at lowering borderline personality symptoms. 2010 data. So SSRIs, atypical antipsychotics, yeah, it's probably where we got to lean, and the epilepsy mood stabilizing meds. More recent one comes out, the findings weren't as robust, but it's still kind of, the anticonvulsants seem to have the more global effect, right? I don't know if they're always as good with anger. I think the atypicals have an edge there, but the anticonvulsants seem to pop out as still the most effective thing we can find. Atypicals, meta-analyses, leaning towards being able to treat your patients. The mood stabilizers, they're just not studied as much. They're not brand name medicines right now, right? But the atypicals, more brand name medicines, more funding, more people doing research. So atypicals, mood stabilizers. If you like the summary, the table in your handout, these are the meds that we use and why we use them. So if you want that target symptom approach with this patient population, I thought that was a good table. Benzos are bad, right? Not for everybody. They're great drugs for certain disorders, but for borderline personality, addiction rates are high. A lot of our folks addicted, they mix them with opioids, they mix them with alcohol, you're flirting with disaster. So we tend not to use benzodiazepines in our borderline personality patients. Fascinatingly, stimulants look pretty good. Every now and then when I'm gearing up for a talk, it's like naltrexone. Wow, it's a lot of naltrexone. Wow, stimulants are really good. Please don't leave here putting all your patients on stimulants. But a lot of our borderline patients come in complaining of what? Dr. Goodman talked about this. ADHD, I can't focus, I can't. And some of them have legitimate ADHD. Some of them are depressed, anxious, and just can't focus because of that. But they get diagnosed with ADHD, they put on stimulants. But it's funny, the stimulants kind of showed some effectiveness. Maybe it brings their frontal lobes online, they have better executive functioning, they don't get as angry. So please don't leave here. And, again, I don't put a lot of my patients on stimulants either, but it's an interesting finding, right? Benzodiazepines, 16% got a study, alprazolam seems to help. 15%, they got worse. Don't do it. Right? You don't know if you're going to get the good or the bad, so try to avoid the benzos. So what do you do when the patient walks through your door? I'll just use this diagram here and wrap up our talk. Assess the patient. If they're mild, they don't make any requests for meds, get them to a good psychotherapy. If they have mild symptoms, they're hounding you for a med. It's kind of like when my kids used to get infections, I'd hound the pediatrician for amoxicillin, and the pediatrician would say, nope, it's not warranted. Or they give it in and they write the script. If you're in that position, go with the SSRI, especially if you see a lot of anxiety in the patient, right? If you have to do something, yes, pick the safer medicine. But on the moderate to severe side, again, I like Gunderson's layout here. If you have a lot of affective discontrol, you can use an antidepressant. But to me, I'll one-up it. Discontrol towards anxiety. Now look at impulsivity or anger. Antipsychotic or mood stabilizer. Try one. If it doesn't work, try the other. If they don't work, combine them. Rational polypharmacy, just like bipolar 1, right? Sometimes you need 2 meds for mood stability. And on the far right, if your patient really is cognitive and perceptual disturbance, they're more dissociative, they're more paranoid, they're more quasi-psychotic, you're going to want to use an atypical. So I think this is the easiest flow diagram I've found, and it seems to make sense in my practice. So I won't show you the more complicated one because it just says the same thing. right? Here's the meds we use and the doses. There's some data. So if you want to know where's the data about meds and dosing, this is all off-label again, but we have a table for you there. Comorbidity, as I said, if you see bona fide anxiety disorder on the top, you gotta treat it. If they have PTSD, treat it. They have OCD, treat it. Don't just send them for DBT and hope that'll get better. So when you see comorbidity, just like an addiction, you gotta treat the addiction and the other psychiatric condition to try to get people better. Substance use, very tough in this population. Again, start with psychotherapy, but we have meds for alcohol use disorder, right? Some of those meds, like the naltrexone type products, help borderline personality too. Sometimes you get in a win-win situation. Be careful with sleeping meds. Some of them are sedating, right? The BZRAs, you don't want to combine them with alcohol or opioids either. They do get people better circadian rhythm, they sleep better, they're more in control of their affect when you sleep better. But just use some of the non-addictive ones, right? So don't get in trouble with those again, just like the benzos. Ketamine, esketamine, maybe lowers depression, lowers suicidal thinking due to depression. My borderline patients are very suicidal thinking. So small studies coming out there for things like ketamine and esketamine. Botulinum toxin didn't work. You saw memantine a lot, a little study. Seemed to work, we just need a big study. So some of the glutamate dampening products. Here's a list of other things being investigated as we speak. So maybe we'll get our first FDA approval. Maybe we're getting closer to that. There's a KDMA1A inhibitor of alphidomestat. Interesting drug. Anybody heard of this? Yeah, epigenetic enzyme lysine, LSD1. Yeah, new player. Fascinating, right? So, we're used to the monoamines, but at least we get to investigate other ways to maybe calm the limbic system, calm the amygdala, the fight or flight centers down.